ASPC is always one of the best meetings for all of us who are interested in prevention. Any first-timers at ASPC? Wow, that's like most of the room here, so that's super exciting. It's an amazing meeting in everything related to prevention, and of course inflammation is a very important part of it, as is imaging, which is what we're going to talk about today. So you have a real treat today. You have a symposium that has the two best speakers in this entire field, and I know both of them very well. They're both good friends and colleagues, and I'm so excited to hear their talks, and that's Dr. Harris Antoniades from Oxford, chair of cardiology there, one of the most brilliant scientists that I know that I've had the privilege to interact with over the last decade, who really kind of put this whole area of inflammation in the spotlight, developed the technology that we're going to talk about. And then Dr. Brittany Weber, a very close colleague of mine, who's really the international expert of the field of cardiorheumatology, and she's brought to the scene here the importance of inflammation in our patients and how to treat that, and she's going to show some cases as well. So Dr. Weber's talk is also something that I'm really looking forward to. But I'm going to start with a little bit of an overview about inflammation. I think we hear a lot about inflammation. You're going to hear a lot about inflammation in the news today as well, and we'll talk later about that. It was a trial that recently came out. But I want to talk about one concept that I think is really important, and that is, why is inflammation bad from a coronary heart disease perspective? And that is, if we summarize all the basic science, and a lot of it came from Peter Libby, one of my colleagues at Brigham and Women's Hospital, it's that inflammation leads to the actual development of plaque, progression of plaque, and then plaque instability and rupture. And I think it's really important to remember that, because some of the trials and some of the data on inflammation we'll talk today are maybe in advanced stages of disease. And then we have less data in earlier stages. And the fact that inflammation contributes to earlier disease development, I think, is very important. We have to keep that in mind. So I'll come back to that later. But when it comes to inflammation, the data so far is that it's both prognostic and has therapeutic inflammation. And there's a wealth of data showing us that inflammation is prognostic, meaning associated with more events. One of the studies published last year for that by Paul Ridker examined, in the Women's Health Study, over 27,000 young women who were in their 50s at the time of the study, and followed them for 30 years. In a single measurement of CRP for a woman in her 30s, was able to assess risk and look at this separation of curves by level of CRP, such that the women with elevated CRP, much higher event rate over 30 years. So this is really a marker that kind of tells us the future a little bit, similar to LDL cholesterol, but in a complementary fashion. So these are women without disease. What about individuals who actually have cardiovascular disease? A lot of us as cardiologists will see in the clinic folks who come to us, they've already had a MI, they've already had a stent. And Paul Ridker looked at this as well in a study that combined data from 3 cohorts of secondary prevention, prominent, reduced, and strength. And the important finding here is that once patients are treated with LDL-lowering therapies, as is the case in secondary prevention, what determines the future risk, more so than whether their LDL is high or low, is whether they have inflammation. So this is one of those targets that we really have not been able to address very well in cardiology, and certainly a lot of trials in this space. But something that we have to remember, that if someone has residual inflammation, that might be even more important than LDL. Certainly both are important. Now, one of the challenges for us has been also how to measure inflammation, and we have measures like CRP. I think a lot of us use CRP, but we also know it's not specific. CRP can be elevated for multiple reasons. And then perhaps another way to measure it is IL-6. And Mike Blaha recently published this paper with his group from a collection of multiple cohorts showing us that IL-6, a very important measure of inflammation that we don't really use a whole lot clinically yet, also is a strong predictor of events even after we account for baseline risk factors. Now, you'll say, okay, inflammation is bad, but how do I treat it? And that's, of course, an area that we're going to learn a lot about, I think, in the next few years. But suffice it to say that there are trials that have shown us that reducing inflammation lowers risk. And I think it's important to understand some of these trials. We may dive into these later. But both in patients who have had a prior MI and then patients with stable CAD, as in the LODOCO-2 trial, colchicine has been associated with a reduction in events, and I think that's important. In the CANTOS trial, canakinumab, which is no longer really used in development for multiple reasons, also showed a signal for a reduction in events. So certainly we have findings that lowering inflammation can be beneficial. But again, the problem is, how do we measure it? We can measure CRP, but it could be elevated for multiple reasons. And as a cardiovascular imager, people have always asked me, do you have any techniques to measure inflammation? What about FDG, which is a very complex nuclear scan? I said, no, that doesn't really work very well for the coronaries. And then, really one of the breakthroughs was the development of fat attenuation index, which is what you're going to hear from Dr. Antoniades, which is the ability to take a coronary CTA, look at the perivascular or pericoronary adipose tissue, and understand if there's inflammation. And this has taught us that patients who have coronary inflammation by this technique have higher risk, and this adds prognostic value on top of plaque, and of course has direct therapeutic implications, because if a patient has higher risk, it's not just about treating inflammation, it's about treating their entire risk profile. So before we go on to our highlight, which is Dr. Antoniades, I will now share with you some really exciting news. Some of you may have seen this in the press. This just happened a few days ago, and that is in the US this week was the FDA approval of a CaRi-Heart coronary inflammation, which essentially is a combination of the fat attenuation index with a risk score. So that is now approved. So the ability to now look at inflammation. I was always envious of my colleagues in Europe and elsewhere in the country. They were able to use this clinically. And even though I've used it for research together with Dr. Weber, it's not something we were able to use for our patients, and that is now changing. So with that introduction, let's turn to Dr. Antoniades. Again, he's the director of the Acute Multidisciplinary Imaging and Interventional Center. He's the head of the Division of Cardiovascular Medicine. He needs very little introduction, and we welcome him now for our talk.
Great. Thank you, Ron, for the introduction. I have to admit, this is my first time in this meeting, but it already feels very exciting. It's exactly spot on to my scientific interests. So these are my disclosures. The most significant one is that in addition to being a full-time academic in Oxford, I'm also founder, shareholder, and chief scientific officer of Caristo Diagnostics. And the technology that is behind the company came from my lab in the University of Oxford. Now, I would like to start by reminding you about the natural history of atherogenesis. For many years, at the early ages, at the young ages, our arteries are exposed to the risk factors. Hypercholesterolemia, hypertension, diabetes, and so on. This triggers an inflammatory response of the vascular wall that in some cases leads to the formation of plaques. And if this continues, then the plaques progress, they become significant, obstructive, and at any point, the inflamed plaques may break, giving heart attacks. Now, the first line of defense in primary prevention is, of course, to target the source, the risk factors, the individual risk factors, which we know very well how to do. Second line of defense, as Ron mentioned, is the inflammatory response. Essentially, if you are able to find these patients and treat them early on, then you never develop the plaque. You may just cool down the arteries and plaque never develops. If we fail in the first two lines of defense, then we go to the third line of defense, which is let's find the plaque early on, and if we treat this plaque, we can stabilize it so it doesn't progress and it doesn't break to give heart attacks. And this, again, is something that we know very well how to do. Now, for the risk factors, we have the well-known risk calculators. In Europe, we have FAI-Score. In the UK, we have QRisk3. Here we have Prevent. So we know very well how to find these individuals who are at risk based on the risk factors. For this last category, those with plaques, there is a momentum at this moment, especially in the US, because with the AI plaque quantification, we can now find these individuals who already have the plaques early on and treat them to stabilize the plaques. But how about this big, very long period where we have inflammation but no plaque? How can we find the individuals who are in the process of developing the plaques? We need to start thinking about systemic plasma biomarkers, what Ron mentioned, IL-6, CRP, and so on. And we need to start thinking about local vascular inflammatory markers, which can come from imaging. I will start from the bottom, from the plaque imaging. Now, we can now very confidently identify and quantify atherosclerotic plaques in the human coronary arteries. There are many AI plaque analysis tools in the US, in your hands. I will advocate for this one, which is the CaRi-Plaque, which I will call the Rolls Royce of plaque analysis. I call it like that for two reasons. Not only because it was developed in my lab in Oxford, but it's developed first, is the only plaque analysis technology that was developed against human coronary plaque histology. It's human, it's coronary, and it's histology. So when you quantify plaque by using this, essentially you perform a virtual biopsy of your coronary arteries. This is from post-mortem CT. And the second reason why I call this the Rolls Royce of plaque analysis is because it's the only tool that is validated against prospective heart outcomes in more than 100,000 patients. This is a study that we presented at SCCT. It will come out as a paper in the coming months. And it's 100,000 patients from all continents, from Europe, Asia, and the US, against heart endpoints. But of course, measuring plaque is probably too late, because by measuring plaque, you cannot really tell if there is inflammation in your arteries or not. In a big study, which is called the Orphan study, which is an international registry, we are now reaching 230,000 patients with CT scans followed up for at least 10 years. We have done the first analysis in the first 54,000 patients, consecutive patients having coronary CT angiograms. During the follow-up period of median of 6 years, we recorded 2,500 cardiovascular deaths, so big event numbers that allows you to understand the epidemiology of plaque rupture. And we have seen that 54% of the fatal cardiovascular events came from these guys with the very big plaques, which is what you would expect that. However, 26% of the events came from those with the small plaques. These are the ones that we can pick up now with the AI plaque analysis. But here it is. 20% of the events within 6 years came from those who had absolutely no plaque. These are the ones with plaque 0, calcium score 0. They gave us 20% of the cardiovascular events. This is within 6 years. Why? What drives events is inflammation and plaque rupture. If you have inflammation here, you may develop plaque within the next year, and then the small plaque may break and still give you a heart attack. Smaller possibility, but you still have these heart attacks, which are potentially preventable. Now, how do we find the inflamed coronary arteries? That has been a topic of research in my group in Oxford for more than a decade. And we found that when you have an inflamed artery, coronary artery, this secretes molecules, inflammatory molecules in the perivascular space, and causes some striking changes in the composition of the perivascular fat. Now, the basic science, you can go to these references, you can understand exactly how these work. I will not get into the basic science details, but the bottom line is that you can use routine coronary CT angiograms, these black and white images. You can use a new technology developed that is called fat attenuation indexing, and you can bring this information to the surface, and if you see this red color, it means the artery is inflamed. If it's yellow, it means the artery is not inflamed. And this is quantifiable. And why is it important to quantify? It's important to quantify because then you can have cutoffs, and then you can act upon these cutoffs. As Ron mentioned earlier, on the 28th of July, that was a few days ago, the FDA authorized through a de novo process the medical device that measures this with the label of measure of coronary inflammation. And this is the only imaging tool that tells you about coronary inflammation and is regulatory cleared and can be used clinically. You interpret this, which is called fat attenuation index score, on nomograms for age and sex. And it has been available in Europe for the last a bit more than 2 years. And there is a consensus statement from the European Society of Cardiology explaining how to use these cutoffs in order to make decisions. In the ACC scientific statement on inflammation, this was mentioned last year as an upcoming tool. Back then it wasn't regulatory cleared, so it was an investigational product. Now it is a clinical product. And in the 2026 guidelines for hyperlipidemia, it is mentioned as a way to measure coronary inflammation. So it is clinically applicable, it is clinically available in the US, and there are some guidelines upcoming now that will tell you exactly how to manage this. Now, if you have inflammation in your coronary arteries measured by using this way, what does it mean? It means that you are at very high risk to develop a fatal or non-fatal cardiac event. This is from the Caristo study published a few years ago, the foundational study of this technology. If you add the fat attenuation index score on top of a model that has age, sex, risk factors, calcium score, and high-risk plaque, then you get this striking improvement of the prognostic value. And in the most recent study that we published in the Lancet a bit more than a year ago, from the orphan study, even in those without obstructive disease, if you belong to this high inflammation group above the 75th centile of the fat attenuation index score, then you get 10 times higher risk to die from a cardiac event over the next decade. 10 times. Now, we have high sensitivity CRP, we have plasma biomarkers. Why do we need an imaging biomarker? Well, the concept with the plasma biomarkers is that they pick up systemic inflammation. It can come from arthritis, from a flu, from injury, while with the fat attenuation index score, you get a specific measure of inflammation in your coronary arteries. Which one of the two is useful? I will say they are both complementary. If you have systemic inflammation, this is from 16,000 patients from the orphan study followed up for a decade. And you can see that if your high sensitivity CRP elevated, then you are at risk to develop a cardiac event because systemic inflammation spills onto the coronary arteries and there's a possibility to cause high local inflammation later on. But if you have the local inflammation in the coronary arteries, again, you are at very high risk, even if your CRP is very low. The correlation between the two is 0.2 correlation coefficient. So they don't tell you the same thing, but they're complementary. And it's important to understand that if you measure FAI-Score and you measure local inflammation, that gives you a stable prediction over the decade, is the red line here, and this is a time log analysis. If you have a single CRP measurement, you get a good overall prediction for the 10 years, but this is driven for the first 2 years. This predicts events for the first 2 years, and then the performance drops. And the added value is essentially observed in the first couple of years. Now, calcium score, you are all familiar with this, very popular test in the US. It's a very powerful tool to stratify risk. However, look at some details. This is from the CAC consortium, 22,000 asymptomatic individuals followed up for a decade. As we expect, 65% of these individuals have calcium score 0. These are the guys that we reassure that they are at very low risk and we don't take any action. However, 32% of the coronary heart disease deaths over the decade happen exactly in this calcium score 0. 42% of the cardiovascular disease deaths happen in this calcium score 0. Yes, the individual patient risk is very low, but because there are so many, they fit nearly 40% of the fatal cardiac events over the decade. So the question now is, are we able to find these 30 to 40% events among those with calcium score 0? The answer is yes. This is from 8,800 patients, individuals, healthy individuals with calcium score 0, followed up for a decade, and this is the stratification based on coronary inflammation. If you have coronary inflammation above the 75th centile, then you are at a very high risk. So we're talking about 8 times higher risk to die from a cardiac event if you have calcium score 0 and you have high inflammation. Calcium score 0, but inflamed, I will say. This is a high-risk group. And even if you go to the whole population, these are 19,000 patients followed up for a decade, then calcium score gives a very good prediction, AUC of 0.76. If you add inflammation on top of that, then you go to 0.82, which is a significant improvement for those of you who are familiar with this ROC analysis. Now, in the clinic, we are very used to apply cutoffs to stratify our patients based on risk factors. Now I'm telling you there is plaque, there is inflammation. How do you take all of this into account to make decisions? Well, AI is here to help us do exactly that. And I'm very pleased to say now that as of the 28th of July, we have the first medical device in the US, which is now clear for clinical use by the FDA, that takes the CT scans, extracts information about plaque, gives you that, extracts information about inflammation, provides that, but it doesn't stop there. It takes all of this into account and tells you what's the revised risk of the patient. So it's like an enhanced prevent score that tells you what is the risk of the patient after you have taken into account the risk factors, of course, and inflammation and plaque. And this is a tool that is very, very powerful in finding the high-risk individuals. Why is it powerful? This is from the Orphan study. We ask this model to stratify the individuals into the 3 risk categories that trigger different interventions based on the current guidelines. Either start statin treatment or add additional treatments like ezetimibe, anti-PCSK9, potentially colchicine. These are not real events. These are the events that the model provided us, predicted that these are the events that will happen. Then we opened the labels, and then we recorded the true events. And these are the true events. These are the solid lines. Dotted lines are the predicted events. Solid lines are the true observed events. So this model not only tells you if somebody is going to have an event, but it also more or less tells you when the event is going to happen. And what do you do when you know that somebody is at risk? Well, if you treat them with statins, we have seen that this, within a year, it reduces this calculated risk, the CaRi-Heart risk, by 40%. And this is sustained for at least 3 years. This is a study published from a group from Europe. And then from the randomized clinical trials, this is one recent example from the Ortigma trial. This is an antioxidant LDL monoclonal antibody. Even within 12 weeks of treatment, you can get 40% reduction of inflammation if you select your patients based on having high inflammation at baseline. And this is important. This is very relevant to what Ron mentioned about the announcements that came out today about the ZEUS trial. If you don't select the individuals with high inflammation to treat them with anti-inflammatory treatments, then you get very small effect sizes. If you are smart and you select them properly, then you get this significant reduction. Now, in the UK, the NHS England has commissioned this technology and is being used in a pilot program in 5 trusts, 5 NHS trusts in 5 different geographical areas. They provide these reports to the clinicians, And they have put together guidance, which is very simple. It looks complex, but it's very simple. The guidance tells you the device, this medical device, gives you stratification of the individuals in 3 buckets: low, medium, high, and very high risk. Then you just apply the existing NICE guidelines in managing these patients based on the risk. So the inflammation adjusts, improves your ability to find the high-risk patients, and then you apply the guidelines. And based on that, they recorded change in management in 45% of the patients who received the test in the UK. 45% of the patients changed management based on this. And they estimate that this will lead to 11% less myocardial infarctions and 12% less cardiac deaths in the NHS in those who have coronary CT angiograms. And I will close with a case. This is a young chap, mid-40s, who had some ECG changes, chest pain, ex-smoker, wasn't very keen to take any treatments, had this scan completely normal. The patient had a fatal cardiac event a few weeks after this scan. How is it possible? Proximal LAD. And the patient died, actually. So what happened? We analyze the scan, and then you see that this patient was on the 99th centile of inflammation in the circumflex and 90th, 89th centile of inflammation in the LAD. So with these values, anything above the 75th centile is high inflammation. So this patient should have received not only statin, but also colchicine and anything we had. Just to conclude, the plaque analysis, the CaRi plaque, is the only AI plaque analysis tool that is calibrated against human coronary histology. It's tested in more than 100,000 patients, followed up for a decade. This AI plaque analysis doesn't tell you about inflammation, it tells you about plaque. And the fat attenuation index score is the only FDA-authorized marker of coronary inflammation, which has a very striking prognostic value on top of CRP and plaque. The CaRi-Heart risk is a new powerful risk calculator using AI to tell you the absolute risk of the patient for 10 years based on the plaque and inflammation and the risk factors. And in the UK, it changes management in 45% of the patients. So it has a very striking effect on the way we practice medicine. I will leave it here. This is my current group in Oxford who is working on these technologies. Thank you. Questions at the end?
Well, that was just outstanding. Here. The question was that a post-mortem scan? And no, it's before the event. So we will have questions and answers later, but we have a totally packed room. This is just really exciting. I mean, I've seen this data before, and every time I see it, this gets me excited as a preventive cardiologist. Not just a biomarker of inflammation, but something that changes our management, and then we can track. I think the fact that it actually changes in response to therapy is really important. So next, I want to again introduce Dr. Weber, because just like Dr. Antoniades was a treat to hear, so will Dr. Weber. I used to work with her at Brigham and Women's Hospital. She's now at UT Southwestern. She's the director of both cardiorheumatology and cardiodermatology programs, which is quite amazing. An assistant professor of medicine and dermatology. And I think the other really important title is she's an outstanding preventive cardiologist, and that's what we're all about here. So, Dr. Weber.
Thank you very much, and thank you guys all for taking the time to be here to this very exciting symposium on the very first day of an exciting 3 days. And this just brings me so much excitement. Dr. Blankstein is far too kind, because not only is he a dear colleague, but he also trained me. And so I've had the pleasure of getting to work with him for a number of years. And I'm going to show you a few of my cases today. When Dr. Blankstein and I started this now, I was actually transitioned as a fellow back in the 2020 area, 21, when we started to do this for research purposes for cases. And as of 2 days ago, it is now FDA approved. So you're going to see some cases from my clinic, my passion of cardiorheumatology. But again, these were all research cases back in the day. But that has changed as of 2 days ago. So again, I'm going to be talking about a little bit of clinical interpretation of the FAI-Score and a few of my own cases from my clinic and some of the therapeutic implications. You've already seen this. You know, it's always the kind of teaching pearl is tell you again what you just learned about, but to everybody remind people, because a lot of people may get confused on these terms, it's very important to remember that this is, the PCAT is the adipose tissue attenuation. It has been shown to be prognostic right here with the hazard ratio. You can see here, though, for the correction for scan parameters is very important, which is the fat attenuation index. And then the further correction for the technical, anatomic, and demographic variables gives us the FAI-Score. That is Caristo's product and is now FDA approved, and that is the FAI-Score with the hazard ratios showing there. So you heard a little bit in Dr. Antoniades talk about how do we assess inflammatory risk when you get this report. So I wanted to show you this because I've been seeing these in the research phase for quite a while. But first you're going to get the FAI-Score, right? And it's not rocket science. You got the green and the red. So, you know, red is inflamed, green's not inflamed. And so you get this inflammatory risk when we get these score profiles. So a FAI-Score less than the 70th percentile is low, medium risk based on all the data you just heard about. If you have a FAI-Score greater than the 75th percentile and less than the 90th percentile, then you are high risk. Again, somebody we want to be treating very aggressively. And then if you have a greater than 90th percentile, you're very high risk. You then get also another score right here, which is the CaRi-Heart risk that you just heard about, and that is the 8-year risk of a fatal heart attack. And so you can see here, you can look at, again, the green, the yellow, and the red, and your CaRi-Heart risk less than 5% would be low, greater than 5 and less than 10 would be high, and then greater than 10 would be very high. And then you integrate those two for your AI risk classification. So again, you know, if you're in that green, this is really where we say, okay, well, we can think about lifestyle changes. You're still going to always emphasize all the things we talk about as prevention cardiologists, but if you're high or very high, this is really where you're going to be talking about increasing in therapies, including things we have today, such as statins and colchicine, and then we've got a lot to learn about how we're going to be treating inflammation in the future as well. And so, And so you also saw this slide again, but I just want to remind you that we had the beautiful orphan study. It's a really great paper. Please take a time if you have not seen it to read it. There's excellent supplemental data as well. But just reminding you, the slide you already showed by Dr. Antoniades that this reclassified 30% to higher risk. So those are people that we would not have identified as ability to treat, and 10% to a lower risk category. You also saw this slide. I did not realize he had this slide in his talk, but I love this slide because this was also in the supplement. There was a sub-study of orphan that looked at a smaller number of UK hospitals, and very important because we are all practicing clinicians, and I think it is so powerful to say, how does this change our clinical management, right? Because that's all the reason we're going to be sitting here doing tests in clinic, right? To change the management and reduce patients' risk. And so you can see here that it had a substantial change and changing patient management, and these are the therapies in the UK by which it changed. But I won't go through that because you saw that slide earlier today. So now I'm going to walk through a couple of my cases that I've been seeing in clinic. These are all cases back at the Brigham and Women's. This is an example of FAI-Score in the young and systemic inflammatory diseases, something I wish I could spend an hour talking to you about today, but hopefully I will have a future opportunity. So this is case number 1. He's a 33-year-old male. He has juvenile rheumatoid arthritis. He was referred to my clinic for prevention. His disease was stable. These are patients that are often on TNF therapy since they were teenagers. He had no flares, and he had a low CRP. He had no known risk factors, and here is his lipids at that time at the age of 33. You can see his LDL was 119, LPA less than assay, and he had a normal BMI. I saw a similar patient not that long after that I was 32 that also had juvenile RA, similarly referred to my clinic for prevention. Anti-TNF therapy is a very great therapy for this disease. They're often very stable on this. He was also on methotrexate. He had no flares. His CRP was low at 1.1. This is low for an RA patient. He had a family history, premature disease in his father, and his lipids had an LDL of 80, a normal lipoprotein A, and a normal BMI. And so both these patients were highly concerned about the cardiac risk. Given their young age, we discussed testing options. In their young age, this is not something I would have, I felt we discussed that a coronary CT would be the better approach given the young age for calcium score, and so we proceeded with a coronary CT. So here I'm showing you the two different cases. Remember, they're pretty similar, but a little bit differences. But case number 1 had no plaque, 32 years old, 31 years old. Patient over here on the right had non-calcified plaque in the LAD. So very abnormal for somebody in their 30s. And so what did I do in clinic? Well, this really did change my management for patient number 2, right? I discussed lifestyle modifications for everybody, risk factor reduction, blood pressure, exercise, making sure their RA disease activity was controlled is very important in these patients. But case number 1, this was now 6 years ago, no therapies were initiated. Case number 2, he had non-calcified plaque in his LAD. Of course, we started aggressive statin therapy. This is a patient that would have never been on statin therapy if we did not find these results at this young age. And so for research purposes back at that time, we also were doing research on this, and we had their CaRi-Heart data here. And what I'm showing you is case number 2, the one on the right. I'm sorry if we can't blow this up, but I'll show you the next slide. This was highly inflamed. He was greater than the 90th percentile, and he had no plaque. Whereas the patient on the right here with plaque did have a little bit of inflammation, but he was not incredibly inflamed. He was in the top artery was in the 66th percentile. And so if you think about it, but which patient had I started therapy on back in the day? I'd started the statin on in case number 2, which he did need because he did have atherosclerosis at the time, but case number 1 did not get any therapy. And so this really begs the question is, would case number 1 have benefited from a statin to prevent the development of atherosclerosis, right? Because you just saw data by Dr. Antoniades, and this is a patient with no plaque, but we have the data that this predicts events even in patients with no plaque. So that's an important point. And so this is an example of how we can utilize this technology to inform and guide our clinical decision-making in the young. I also want to tell you about one study that I'm very proud of recently publishing with one of my mentees and also colleagues, Dr. Antoniades, who also trained with his PhD with Dr. Antoniades. He came to work with us at the Brigham, and Dr. Blankstein and I, and we utilized patients from our own registry at the Brigham with systemic inflammatory diseases. So we took patients with lupus, psoriasis, and rheumatoid arthritis, and we took patients that had retrospective coronary CTs. And then we also sent them for FAI-Score analysis, and then we looked at their prognostic value. And this is an important question. So is FAI-Score prognostic in patients with systemic inflammatory diseases when they're already on biologic therapy? The majority of these patients were on biological therapy. And so similar to the analysis you saw earlier, we divided the FAI-Score greater in the quartiles, and you can see here on the top curve, the patients with this cohort with systemic inflammatory diseases that had the highest FAI-Score had worse all-cause cardiovascular outcomes even after adjusting compared to the lower quartiles shown here. And we also looked at a subgroup analysis shown here on the right where we saw prognostic significance even in the young, so it did not depend on the age, and even on patients on the biological therapy, which is shown right here on the right. So this was even in patients with JAK inhibitors and biologics. And so you then may ask, well, can we be utilizing this score to track changes and inflammation? And this is kind of the big thing we're all going to be working on moving forward now with the recent approval of this technology. Again, for research purposes, I worked on rheumatoid arthritis for a number of years. We did a study at the Brigham where we looked at anti-TNF therapy in patients with rheumatoid arthritis, and this was one of the patients that was referred to me in clinic back in 2019. And what you can see here is that she had a FAI-Score that was great. She was a very younger patient, so she had a 83rd percentile FAI-Score risk, so very inflamed at the time. And then for her treatment for her rheumatoid arthritis, she was put on a TNF inhibitor. She was on, I think, certolizumab at the time, and then transitioned to a different one. And a couple years later, we had a repeat coronary CT and CaRi-Heart analysis, and you can see here the lowering of inflammation to the 17th percentile. So just showing you how this can track changes. I'm going to show you one more case because I do want to make sure that we have some time for questions. This is another one of my patients. Psoriatic arthritis and psoriasis is another disease we do research on and we think a lot about in terms of how do we understand that increased cardiovascular risk. This was a 61-year-old male that came to my clinic with chest pain. Here is his risk factors. He had hypertension, hyperlipidemia, and psoriatic arthritis, and he was on Humira. You can see here his lipids at that time. He did have an elevated lipoprotein A. His CRP was elevated when he saw me in clinic. And it's very interesting because if you were to, when I calculated his risk score at this time, he was elevated risk, but this is a patient that had not come to me on any therapies, but he was having some symptoms at that time. and he had recently had a pharmacologic MIBI that was negative by an outside cardiologist, and they said, okay, you're good, do nothing. And then he came to the cardiorheumatology clinic. So what did I do? I proceeded with the coronary CTA because I had a high pretest probability based on all this data, and this was the coronary CT findings. And I still remember I was driving home, and back in the Brigham and our L2, our radiology fellows, cardiac imaging fellows, one of them called me and told me about this CADS RAD4 result, and it's not a result you want to be getting when you're driving home, because I had to call the patient about this and say, you actually have very aggressive coronary disease. You have 3-vessel disease with severe left main stenosis. So again, he was shocked, but also incredibly grateful. So what did we do? Well, we do what everyone else in the room would do. We did a coronary angiogram next to confirm these CCTA findings, which was confirmed, and then he went to CABG pretty quickly. He's still doing great. I saw him for a number of years, and I think I last saw him in the fall last year before I transitioned. He completed cardiac rehab. He lost 10 pounds. We got him on all the standard prevention therapies. His LDL has been low. His blood pressure is controlled. And he was back on Humira after the CABG, but the rheumatologist was planning to step up therapy given active disease. And really, this is the food for thought. This is what we're going to be learning, especially as data was released this morning, is what is the anti-inflammatory therapy we need to be adding, both in the general population as well as the populations with systemic inflammatory diseases. And this is just a food for thought, right? Because I don't know the answer to this, particularly in a PSA patient. But this is his FAI-Score for research purposes back in the day, and you can see not only did he have aggressive plaque, he had an incredibly inflamed score. All 3 of his arteries were higher inflamed. He had a 30% risk of having a fatal cardiac event in 8 years. And so luckily we were able to catch this before then. So you saw a little bit about this but can FAI track dynamic changes in response to therapy? Well, I would argue that the early data is suggesting yes, but this is what I want to challenge all of us in the field, because this is where we need to continue to have more data. I love this paper on the right because I love my field of cardiorheup cardioderm. This is an excellent paper published by Dr. Mehta showing the FAI-Score reduction in psoriasis patients when they've been on biologics for 1 year. We also have a paper shown here by the reference of changes of FAI-Score lowering in the post-STEMI small cohort, and then you saw Dr. Antoniades mention the data recently on post-statin treatment. But again, something that I'm very excited to see more data over the field. This, I already showed you this, so what I want to do is just kind of walk you through. This is brand new for all of us, right? This was just now FDA approved, but they've been utilizing this in the UK, and so what does the clinical workflow look? Well, the good thing to remember is this is just like all the other things we have often been adding on with AI quantitative plaque, is this is all data that can be acquired after you've gotten the coronary CT. You do not need to do anything differently. This works on different scanners, different parameters. It works on photon counting CT. So you take an acquired routine coronary CT, and then you will submit it through a secure cloud, shown here, to these DICOM images, and the Caristo AI then analyzes this in the cloud and then sends it back, and you saw what the reports look like by just what I showed you today. So I'm going to sum up with key takeaways because I hope we can have an interesting discussion. We talked about how FAI-Score is strongly associated with incident cardiovascular risk in MACE, and remember that this is increased risk in both non-obstructive and obstructive CAD. We talked about how FAI-Score and the CaRi-Heart risk score can then be added on to any previously acquired coronary CT to identify individuals at higher risk of events who may benefit from more aggressive prevention, and identify individuals more likely to benefit from anti-inflammatory therapies such as colchicine and the future of the other targets to come, and then monitoring response to therapy, which is now being done in some of the clinical trials. And so thank you very much. I'm looking forward to discussion.
That was outstanding. We're going to open it up to a Q&A. I'll invite Dr. Antoniades to join us here. So I'll ask folks if folks have questions. If not, we have a couple topics to discuss. But I'm going to start with one question, and I'm going to take that folks ask me all the time, which is, in your practice today in the U.S., how do you lower inflammation? I think a lot of people ask that question, and I'll just give you 4 things that I do. Number 1, lifestyle. Yes, diet and exercise. Diet actually can absolutely lower inflammation, a better diet. we can get into that later, how exactly. Number 2, statins. Statins do lower inflammation. I think it's important to know that, especially when we're adding on additional agents on top of statins. A very common question for patients, do I keep the statins now that someone's on a monoclonal antibody if I'm concerned about inflammation or getting effective LDL? Then yes, the statin is still important. Number 3, and I think we have all talked about this, GLP-1 receptor agonists, a very potent reduction in inflammation with those. And number 4, of course, colchicine and low-dose colchicine is available in the U.S. for specifically for this. So now with all that, we did mention the Zeus trial, and I want to kind of, has anyone heard of the Zeus trial? And so this is a lot of you did, and these are results that actually were just released this morning in the U.S. So I want to help you digest this because there'll be, I think there's some noise about this study, so it's important to know. So Zeus is a trial that took individuals with ASCVD with chronic kidney disease, and they randomized them to have a monoclonal antibody to IL-6 called ziltivekimab. And we just heard that the top-line results, negative study. This is going to be presented at ESC. And I think we have seen in the inflammation field both studies that have shown efficacy and those who have not. So it's always hard to digest all that. So I'm going to turn to the 2 biggest experts in the field here to just give some preliminary thoughts. I have some of mine, and I'll save those just if you have anything you want to share with the audience on that.
Yeah, I'll give a few comments on this. If you go back to the CANTOS trial, you will remember that it was a statistically significant reduction of risk with canakinumab, but it wasn't that striking. The overall reduction of risk was, I think it was something like 18% for MACE or something like that, so it wasn't striking. Now, if you look into, and we need to look into the results more carefully, but from a high-level perspective, the Zeus trial has shown a trend to reduced events, which didn't quite reach statistical significance. Now, how would the result differ if the patients were selected for treatment based on their coronary inflammation? If you were treating those who did have the inflammation, would you have a statistically significant result? That's the million-dollar question. Because at the moment, we give a blanket to everybody based on some clinical indication, right? An anti-inflammatory agent, which is very specific, anti-IL-6, and you expect to reduce risk. You will never get a striking reduction. You'll be lucky if you get a statistical significance, but it will not be striking. You need to be clever, smarter, and select the patients properly. That's my
So I guess
take.
My interpretation of that is not everyone has inflammation, and just because they got into the trial because of a high biomarker, serum biomarker, doesn't mean that they have coronary inflammation. And if only we had a test at the beginning of the trial to only include patients who had inflammation, that certainly could have a very different results. Oh, by the way, we do have such a test. But let me turn to Dr. Weber to ask her thoughts on this. This is really complex. I would never do this to speakers unless I knew they were the 2 most sophisticated speakers in the world on this, to put them on the spot on a trial that we know nothing about. We just heard the top-line result this morning. So, Dr. Weber.
Yeah, so thank you, Dr. Blankstein. This is what he does. This is what mentors do, right? They theory the hard ones in the middle of the morning. So yes, we did just wake up to these results. So I'm not going to speak at high level because I have not even had time to go through these data myself, but I can give you probably a perspective as an immunologist. So what I will say is it's complex, right? And that is really what we all know. I have been thinking about the immune system and thinking about patients with autoimmune diseases since I was very young, and what we have continued to learn, and I'm always up on stage saying lessons from cardiorheumatology, and I will tell you that we have a lot of lessons we can learn. We have a lot of examples in cardiorheumatology where we have very strong belief that certain targets are going to have very strong outcomes, but then they have unanticipated side effects. I think JAK inhibitors was one that many people may know about, but the oral surveillance. I spent a lot of my last couple years with this new new clinic of how we think about JAK inhibitors that had a MACE warning that led to a big black box label. Still a great treatment for rheumatoid arthritis, but clearly remembering that the inflammation is all a balance, right? There are unwanted side effects of blocking inflammation, and so I think we've got a lot to understand based on the people that were enrolled in the trial, as we already just discussed, and how we think about blocking certain pathways within certain contexts. I will also add that, as many people know the colchicine story, we do know that the context of which we're giving colchicine in does matter, right? Not in every context have we seen therapeutic benefit. So I think that it just means we're just getting started.
So no, that's spot on, and I'll just add to those very important comments, just my own additional point, and that is, we mentioned, both Harris mentioned this, I mentioned this, is the word early. In prevention, you're going to hear throughout ASPC meeting, we need to start prevention early. And I think taking patients who already have CKD and advanced disease and established ASCVD is a very different cohort than the folks that we often want to prevent the development of disease or progression of disease in earlier stages. So we cannot extrapolate results from a kind of end stage population with very advanced disease and take those lessons to a lot of the patients that we are seeing in our clinic, which have on kind of the other side of the spectrum. So certainly a lot to digest there, but I want to open it again if folks have questions. Yes. Well, I think this is the only technology available today to assess for inflammation. So there's certainly a lot of other technologies to assess for plaque out there, and you mentioned two of the kind of the two biggest ones that are used in the U.S. But this is kind of a different dimension. So certainly those other technologies at this point do not have an approved method to assess for inflammation.
So I can add something.
So
here.
we can ask.
This technology that we presented has a quantitative plaque analysis component, which is what I call the Rolls Royce of plaque in my talk, which gives you exactly the same result, the same concept as the Clearly and the HeartFlow plaque analysis. Exactly, the non-calcified plaque volume, the calcified plaque, but this is calibrated against histology. Then it gives you the inflammation, which is completely different, proprietary and unique. And the third component is the risk model, which is also part of the regulatory cleared medical device that combines the plaque and the inflammation together with the risk factors and gives you the amended risk of the patient. Yeah, it does everything in one package, yes. Yeah. Flow, no, we don't. It doesn't have flow.
No.
It's plaque. It's plaque. It's inflammation, and it's risk, and it's absolute risk prediction, not a staging. This is an absolute risk.
We'll move on to the first row here, Roger.
Yeah. He came in with really, I say chest pain on the slide, but he really had more shortness of breath, but with exertion, and that. Say it again?
He was clinically impressive. There were substantial symptoms. He wasn't somebody with minor symptoms and bad.
So I believe when I saw him, I was concerned by his symptoms. He came to me with another cardiology report of a negative pharmacologic MIBI at the time, and they said do nothing. And he was not exercising very much because he had psoriatic arthritis and he had bad knee pain. But when I teased out his symptoms, I really felt like they were significant enough that I did the coronary CT that day.
Obviously, the default answer is angiogram bypass. But given all of our tools about reducing lipids and treating inflammation, I wonder if it crossed your mind or his mind to aggressively treat all of the, treat him medically and not put him through bypass because bypass is nice, but it doesn't. It has its own set of
It's a great question, and we've had a number of cases, and Dr. Blankstein have had a number of these cases over the years in doing coronary CT where we've had, what we are concerned about with aggressive plaque that we treat, right, with aggressive prevention therapies. I will say his case was quite substantial because of the severe left main stenosis in the 3 vessels. So that's really what, pushed us towards CABG. But you raise an excellent point, and I do think in cases not that significant, it would be aggressive therapy, like you said.
Yeah. And we actually use that a lot for patients, I think, that often get revascularized. So certainly we are both very aggressive on prevention, as I'm sure many of you are. You're here at the ASBC meeting. But Dr. Post over here.
Yeah, thanks for the really wonderful presentation. I had 2 questions. It would be really helpful if we could see what the actual report looks like relative to the last question. And I don't know if you have a slide on backup that shows that. So we see, you get the FAI-Score, you get the plaque, what the plaque analysis looks like, and then you get that total risk score. But my other question, which is unrelated to that, is I was wondering if you could provide some insight into who would be the appropriate patient to get this test, which boils down to getting a coronary CTA, and some of the patients presented had symptoms, like Dr. Weber's patients. Some of the patients didn't have symptoms, and so just for all the preventive cardiologists in the audience, what's approved by insurance, and what would you recommend based on your expertise as to who should be getting a coronary CT angiogram, which is the first step in order to be able to get the FAI?
So the first question has to do with the report. In that case, I'll mention this was at Brigham and Women's. This was done as not as a clinical product, obviously it was not FDA approved yet, but at that time the report, and we're going to go into a sample report. I don't think we have it for particularly Dr. Prost was asking for that case, but I think the important information we got there is the FAI-Score and the percentile. And we look at the percentile for each coronary artery, and if it's over 75th percentile that's inflamed, then maybe we have, I don't think this is just an example of the report here, and you see both the FAI-Score on the left here, and then you see on the right the actual percentile for a patient. Do you remember again for that patient the highest percentile? It was.
If you go to that one side of mine, is that you get you get the FAI-Score, right? And the FAI-Score is in percentiles, and then you get the CaRi-Heart, and the CaRi-Heart is a risk score, which is the 8 years. So you get the inflammatory risk, which was up here, and then below that you get the risk of fatal cardiovascular event, and then you put those together for the AI risk classification. Now, this was a couple years ago, these cases. Now, this was before the plaque technology, Dr. Antoniades, so I don't know if he has an example of what the plaque looks like with this, but this was what we would get for the coronary inflammation.
But for this patient,
what I'm asking is, does the score incorporate the total
plaque? Yeah. So these did not, but that's what. Yeah.
So the inflammation alone was what we focused on for this case. The percentile here. Do you remember what the percentile in here? I remember it was very high. I know this case.
For the plaque?
Yeah.
Oh, it was very high, but I don't have it on.
I think it was like 90th percentile on the inflammation.
Right, but I mean, in general, if we ordered this test,
what would the results look like with plaque? And I don't have an example of that. But
there's a separate score report for plaque, so we're focusing on the inflammation. But let me get to your second question, and then I think that might be our last question. So who would you do this in? And I think the important first step is a clinically indicated coronary CTA. So we're not advocating everybody in the world needs a CT who doesn't have symptoms now because of this. So, and of course that's clinically indicated CTA. Mostly is going to be in the U.S. symptomatic patients. We know there's a class 1 indication for symptomatic patients with stable or acute chest pain. We also sometimes will do coronary CTA in asymptomatic patients. In the recent dyslipidemia guidelines, the class 2B indication, specifically a selective use of CTA in patients who may have a higher likelihood of having non-calcified plaque. So if a CT is done for clinically indicated reasons, this is now an add-on test that provides extra information for that group.
So just to add, so there's a separate report for plaque that gives you very similar readouts to Clearly and HeartFlow, which is the volumes of calcified, non-calcified lipid-rich plaque, typical reporting. I'm sure you're familiar with that. And there's a separate report that tells you about the inflammation and the risk. And the risk takes plaque into account as well at the background. Even if you don't request to have the plaque, that is taken into account from the risk.
We have other hands up. Unfortunately, we are out of time, so you're welcome to come here and ask us the questions, but we'll have to end it right now. So thank you all.
I